All right, so that brings us to recently approved drugs that are out there getting a lot of attention, both in the lay media and in the medical literature. What are the big ones out there? There's Provenge, you mentioned. There's Ipi, right? Dan, why don't you walk us through?
Yeah. So I mean, just so we can just dive into these a little bit. Let's just go through a little bit what the clinical data is and really what the mechanism is of how these drugs are working. So I'll take Provenge, for instance, because that's relevant to my field, prostate cancer. So this is an autologous cellular immunotherapy. As Jeff alluded to, it's cellular. It's from the patient's own cells of their body. It's really the ultimate in personalized therapy. The drug is made from the patient's own cells through a process called leukapheresis, where those cells are then shipped off to a centralized lab and activated ex vivo against antigens that are relevant to prostate cancer, in this case a fusion protein of prostatic acid phosphatase and GM-CSF, an immunostimulant. That creates, within that peripheral blood mononuclear cell compartment, some activated cells against those proteins, which are then reinfused back in 3 days later, almost like a blood transfusion for the patient, an autologous blood transfusion. It's done every 2 weeks for 3 doses, so it's a 0, 2, and 4 week regimens over in a month. And the clinical data from 2 independent clinical trials, one a relatively small randomized study demonstrating an overall survival advantage of about 4 months, and then a second pivotal trial, 512 patients randomized and demonstrating again about a 4.1 month improvement in overall median survival with a hazard ratio of about 0.77. And interestingly, to Jeff's point, when you look at this, the patients that live longer derive a greater benefit. So at the patients, if you do a landmark analysis at 1 year, is about a 12% improvement in survival. But you go out to 2 years, it's about a 24% improvement in overall survival. The patients that are out to 3 years, there's over a 32% improvement in overall survival for that population, showing an absolute benefit that's much greater. Yeah. So when you get out there, the absolute benefit of that is really dramatic. So the point is that identifying the patients who are destined to live 3 years are ideal to treat with Provenge.
Okay, and again, you're only giving those 3 doses.
That's right.
Right. So that whatever the cost of those 3 doses is, that's it. So you know up front what it's going to cost.
But the benefit is extended over the lifetime of that patient. It's not a $100,000 cost for 1 month. It's an investment in a patient that we believe is going to live 3 years or more. That's going to be, if you annualize that out, it's $30,000 a year.
Now you're talking like an MBA. But
maybe I am ready for this.
Maybe, but I think what comes back to the point we were making before, it's the gift that keeps on giving. Once you get the immune system revved up, if it works, you've done it.
Yeah.
You've immunized in a real sense.
Well, I don't want to make it sound like it's a black and white thing. I mean, this is against one antigen that may or may not be relevant. Some of these patients, many of these patients, may not necessarily fully respond to that. There may be ways to boost this. I view this more like a platform. Because it has very low toxicity, there really isn't a long-term residual toxicity that follows these patients from this treatment. There's the opportunity to build on this with subsequent therapies, whether they be targeted, whether they be immunologic or otherwise. So, to me, this is the beginning of the story. This is not a, we've checked the immunotherapy box, that's done. This is recognizing, okay, we've started down this path of immunotherapy now with this agent. How do we build on it? How do we improve it?
And where does Ipi fit in this whole group of pharmaceuticals?
Well, Ipi is a very different drug. Provenge is a vaccine, again, the first cancer vaccine ever approved by the FDA. But Ipilimumab is a checkpoint protein inhibitor. So again, on the immune system, you have brakes and you have accelerators. Actually, the immune cell has multiple brakes and it has multiple accelerators. So for the accelerators, if you had a drug that bound the accelerators, you would push the immune system. It turns out that in the cancer-bearing state in chronic infection, the immune system is suppressed. And you have high levels of substances that are essentially the brakes, like CTLA-4, PD-1, TIM-3, LAG-3. My God, I could name a half dozen of them. One of the predominant ones is CTLA-4. And in the cancer-bearing state, you have lots of CTLA-4 on your immune cells, which means they don't work very well. It's like trying to drive a car where the brake is constantly on. You can push on the accelerator all you want, the car is not going to go very far. But if you could cut that brake cable or release the brake, then now you can push on the accelerator and the car can drive. And that's what Ipilimumab does. It blocks the breaking mechanism. And about 15% of the patients will have traditional anti-tumor responses, and there will be a clear increment in survival over time. And the survival benefit plateaus out, meaning you have the same proportion of patients alive at 3, 4, 5, 6 years. So some of those patients may well be cured, which is unique.
Tell me about the safety. You alluded to safety with Provenge. And what about Ipi? Are these relatively safer drugs than traditional chemotherapeutics?
Well, they're different. They have a different safety profile. With Provenge, because we're activating ex vivo this component of the immune system, this cellular component, when this is reinfused, there's an infusion reaction, likely the induction of cytokines within that cellular mix. That's resulting in a very acute, short-term, generally pretty mild inflammatory profile, fever, chills, back pain, what have you. Generally very self-limited, less than 3% incidence of grade 3 or what we'd consider serious adverse events for any one of these toxicities, and very short-lived, completely resolving within 24, 48 hours in the vast majority of cases. So, so not a cumulative toxicity, not a residual toxicity or end organ damage that we're seeing with it, which is different than, say, what we see with chemotherapies or even targeted therapies in some circumstances.
What about Ipi?
And by the way, and vaccines, the beauty of a vaccine against cancer or any other substance is they will not be toxic. We all agree with that. Ipi and PD-1 antibodies are a different scenario because here you're breaking tolerance. So again, we're always tolerant to our immune system is tolerant to our self. If you break that tolerance and indirectly increase the ability to recognize the cancer, you're going to have some collateral damage. And about 10% of the patients who get Epi, maybe a little less, will have grade 3 and 4, meaning clinically meaningful, serious adverse events that we call IRAEs, immune-related adverse events. And that's colitis, inflammation of the pituitary or hypophysitis, low thyroid, rashes, rarely pancreatitis or hepatitis, all manageable, and I probably spent 8 or 9 years figuring out how to manage these things, and I've written on it extensively. But there will be a cost and side effects.
And I don't want to leave, since you mentioned cost, without coming back to, we're going to spend a lot of time on money. I mean, money is where a lot of the action is now in healthcare. These are expensive treatments. I mean, you hear $100,000, $90,000. That's a lot of money. And yet you say you can amortize it.
Yeah, when we think about how this drug is working and the mechanism of how we're judging this, I mean, Jeff brought it up himself. Overall survival, that is the goal. That's what we're judging these drugs by. So because of that, we shouldn't be judging our costs so short-sighted as what's the cost for that month. We should be looking at it in terms of the course of that life.
There is another kind of unspoken thing, which is that it doesn't work in everybody. Why it doesn't work in everybody, I don't know, but it doesn't work in everybody.
Name me something that does.
So the history of oncology is it doesn't work in everybody. So I think, again, not as a pair, but sort of as an interested party, I'd love to know who it works in and why.
Well, the FDA would agree because, as you're probably well aware, biomarker development for patient selection is a huge priority at the FDA. It certainly is a huge priority in our field. In fact, that's what my lab works on with Ipi and with PD-1 antibodies to try to figure out how could you have a predictive biomarker. If you have a predictive biomarker, you're going to make that treatment more effective in a significant proportion of the population. You're going to select out the patients who aren't going to benefit.
And the reason I bring it up is this. In patients who do not respond, they bear that expense, and then they bear the expense of the next therapy down the line, and perhaps have a different clinical course that uses all kinds of other resources. So the real question is, where does it work in? Why does it work in those patients? Can we chart patients on a certain course? That's why, I think the idea of precision medicine is such a sexy idea. Chart patients down a certain course. Although, those aren't curative therapies. Yeah.
But that's why Aetna should be supporting the research into the biomarkers.
So I've been told many times that we're not a research institute. So I've stopped trying to fight that battle.
But it's not just research. It's a way to make things have a greater value and essentially over time save money.
But doesn't this bring us to the